It's a pleasure to have a friend giving grand rounds today. Stephan Munich is someone I've known, we were just talking about, probably for 16, 17 years since our days in Buffalo. But he's currently an associate professor in the Department of Neurosurgery, Otolaryngology, and Radiology at Rush Medical Center in Chicago. And he received his medical degree from University of Buffalo and then completed his residency at Rush University as well. He completed a cerebrovascular and skull-based fellowship at University of Miami, and then a second fellowship in endovascular neurosurgery back in Buffalo. He currently serves as assistant residency program director and director of skull-based neurosurgery. And today he's going to be talking to us about surgical management of intracranial atherosclerotic disease. So, and if you have questions, please put them in the chat and we will go over those at the end. So thank you, Stephan, and look forward to hearing your talk.
Great. Thanks, Mandy. So yeah, I will talk about surgical management of intracranial atherosclerotic disease, which to some may be somewhat of a controversial topic, but hopefully I can convince you that there's a role. All right, so I have no disclosures relevant to this talk, but this is sort of what we'll cover today, an overview of intracranial atherosclerosis, and then some of the treatment managements, obviously focusing on interventional and surgical managements. So ICAD is something that affects 20 to 40 per 100,000 people worldwide. There's an age association with it being more prevalent as we get older, and there's a significant ethnic association with it being most common in Asian populations. Despite that, there is sort of differences in sort of how ICAD behaves among ethnic populations. So the ICAD in Asia is different than the ICAD in North America and in Europe. And so, the usual risk factors exist for ICAD, the usual sort of cardiac risk factors that we think, both modifiable and non-modifiable. But interestingly, with ICAD, the things that we think about for coronary artery disease, such as diabetes and metabolic syndrome, are actually less influential for ICAD. And really the sort of main drivers of ICAD are age, ethnicity, and hypertension. And, it's not the same, although we think of atherosclerosis sort of being the same everywhere. It's actually not the same as in the coronary artery disease. The changes in cerebral atherosclerosis occur later in life compared to the coronary arteries. It's more related to lipid laden plaques as opposed to calcium deposits. And there's no destruction of the internal elastic lamina. In the intracranial athero, we tend to see intraplaque hemorrhage or thrombus rather than, again, calcium that we see in coronary arteries. But we tend to say when somebody comes in with a stroke or ischemia, we say, oh, it was due to atrial fibrillation, or oh, it was due to ICAD. But when we say, oh, it's due to ICAD, we're not really telling the full story, because there's several mechanisms within ICAD that can cause stroke. One of them is plaque rupture, where, again, sort of self-explanatory, the plaque ruptures and either sends an embolus downstream or occludes the vessel at the level of the plaque. We can have hemodynamic compromise, where the plaque sort of creates a stenosis, and then we have flow-related issues distal to the lesion. Or, pardon me, we can have branch vessel occlusion, where the plaque covers small branches, particularly around the brainstem or in the basal ganglia, the lenticulostriate vessels. And I hope to show you that it's important to differentiate these mechanisms. And, on MRI, these look different, right? So we can have sort of embolic phenomenon or plaque occlusion, or we have perforator occlusion, something like this, or we have our border zone watershed infarcts. And interestingly, when we look at the data from Sampras, which I will go into a little bit in more detail later, but when we look at the data from Sampras, the patients who had border zone infarcts or watershed infarcts were the ones who actually had the highest risk of recurrent stroke in that medical arm. So again, this is taking the Sampras data and sort of dividing it according to stroke mechanism. And again, the border zone patients were complete outliers compared to the other mechanisms of stroke. And when you sort of think about it intuitively, does medical therapy make sense in these patients? If they have a hemodynamic failure, if it's a flow-related issue, how would an antiplatelet help that? And we'll go into that a little bit more later. Within the Sampras groups, we saw that patients with higher degrees of stenosis had a higher rate of recurrent stroke. And if they had poor collaterals, they had higher risk of recurrent stroke. So again, I think this kind of speaks to the flow-related issue and identifying the mechanisms that are causing strokes in intracranial athero. Now, if we combined people who had border zone or watershed infarcts with impaired collateral flow, we could see almost a 40% chance of recurrent stroke. So, and this is in the medical arm, I don't think we would ever call something an effective treatment if there's a 40% chance of recurrence. So how do we diagnose ICAD? So, the typical vessel imaging that we think of are MRA and CTA. And MRA is actually notoriously not great for ICAD, and it tends to really overestimate the degree of stenosis, and oftentimes it will call a stenosis a complete occlusion. As you can see down here, this on MRA, this looks completely occluded, but on CTA, it's not. And so we really tend to shy away from MRA, traditional time of flight MRA for intracranial atherosclerosis. TCDs can be useful. We'll go into that a little bit, but it's very operator dependent, can be affected by the bone windows and the sort of enthusiasm of the tech, whether or not they want to pursue trying to get a window or not. So, not every stenosis is clinically significant. So how can we assess for that? Right. Well, obviously, one of them are symptoms, if the patient's having symptoms related to that stenosis. But then there's also imaging mechanisms that we can use, and sort of what I refer to as physiologic imaging, trying to understand not just a snapshot in time, but really understanding how this is relating to a patient's physiology. And so we can do this with catheter angiography, with perfusion imaging, with the addition of a Diamox or acetazolamide challenge, and then using a breath holding TCD. And again, I think it's even in patients with asymptomatic atherosclerosis, you can see that there's a relatively, it basically increases your risk of having a future cerebrovascular event and is predictive of that. So, understanding how to evaluate this and what somebody's risk is, even if they're not having symptoms, I think is important. So with catheter angiography, it is the gold standard. As we know, it's the most accurate method to quantify the degree of stenosis. But I'm showing you a still shot here, but what angiography can also tell you is if there's hemodynamic significance, is there a flow delay beyond the stenosis? And we can image that, and how effective are the collaterals in getting to the territory that's distal to the stenosis. Sort of the way I describe it to patients is that on a CTA, what you're doing is basically, it's as if somebody's running a race and you're taking a still shot, a picture of that person running the race. You don't really see how they started, how they're finishing. You only see them at that snapshot in time. But doing an angiogram is like taking a video of somebody running a race. And so you get to see, how they start, how they finish, how fast they're actually going. So perfusion imaging, I think, is, again, physiologic imaging. It's really the assessment of the cortical or parenchymal blood flow. So it measures the response to alterations in blood flow more proximally. So like when we use aspects or when we use an MRI with DWI, what we're really seeing is the results of the alterations of blood flow. We're not seeing the response. And so the perfusion imaging can be used to demonstrate or sort of predict that response and assess collateral. So I sort of think about it as more proactive imaging, sort of telling you what is going to happen without an intervention. So the perfusion imaging is, really functions on the basis of cerebral autoregulation. And so when the capillary beds dilate in early ischemia, we don't see any change in cerebral blood volume because that dilation is sort of the compensation for the ischemia. And then as that ischemia progresses or there's drops in blood pressure and autoregulation is sort of overcome, then we can no longer compensate. That's when we see those changes that may become fixed. And so, you can see in this left occipital, parietal occipital region that there's a decrease in blood flow and an increase in transit time, but no change in blood volume, suggesting that this area is at risk for ischemia. When we use the acetazolamide challenge or Diamox challenge in perfusion imaging, it's basically analogous to the adenosine cardiac stress test. So we do a baseline perfusion study. We administer Diamox. Diamox is a vasodilator, and then we should see an increase in cerebral blood flow and a decrease in the mean transit time in a normal situation. When we have an abnormal situation, those capillary beds distal to the stenosis are already maximally dilated in an effort to compensate for that stenosis. And so we might see no change, or we might see a paradoxical decrease or a Steele phenomenon in the cerebral blood flow. And so here we see in the time to peak, this is the pre-Diamox, this is the post-Diamox. So basically the blood flow is even less after Diamox, suggesting that this person has already maximally dilated, has already basically exhausted their compensatory mechanism. So if they were to experience some drop in blood pressure or some physiologic challenge, they would be at a high risk for having a stroke in that territory. TCD with breath holding basically is the TCD version of the Diamox study with perfusion. So when we hold our breath, our CO2 increases, and that dilates the blood vessels. And so we should see an increase in our blood flow in a normal situation due to that dilation. And so basically you create this ratio of pre and post, and here's sort of the interpretations of it in the top right. You can have demonstrate impairment of cerebrovascular reserve in this way. Again, the TCDs, this is a little bit less reliable because the TCD part of it is affected by the tech, and then you have to hold your breath for 30 seconds, which can be challenging, particularly in patients who are affected by ischemia. So, it's not just a research parameter. This is demonstrating basically the risk of events with preserved cerebrovascular reserve. And this is now with impaired cerebrovascular reserve, and this is asymptomatic and symptomatic patients. And so if you have impaired cerebrovascular reserve, the odds ratio of having an ischemic event in the future are quite high. If you're symptomatic with impaired reserve, it's even higher, which makes sense. And the original data for this actually comes from looking at extracranial stenosis in patients undergoing cardiac bypass, and they were trying to assess the risk for stroke. And obviously there was an increased risk in patients who had a stenosis or occlusion and exhausted their cerebrovascular reserve. But interestingly, the risk of stroke was not increased if you had normal cerebrovascular reserve. So even in the presence of a stenosis, if you were well compensated or had adequate cerebrovascular reserve, your risk of stroke was no different than somebody who did not have any stenosis. Looking at the Rotterdam study, there's an increased risk of death with impaired cerebrovascular reserve. So, it's not just a like research sort of esoteric academic exercise. It really does have true physiologic uh, consequences. There's sort of newer data to look at plaque enhancement, and this is what I referred to about MRA, the traditional MRA. We actually do use MRA with vessel wall imaging. And in this study, all the patients who had a stroke within 1 month basically had plaque enhancement on their MRA. And I do a comprehensive cerebrovascular clinic with one of our stroke neurologists, and we've actually seen regression of the enhancement as people as risk factors become more optimized. So I think probably more to come on the plaque enhancement part. So we'll sort of transition here to treatment. And I think in order to understand sort of the approach we take now, I think it's important to understand some of the historical notes of the treatments for atherosclerosis. And I would say it kind of starts with the Wasset trial, which was really a multi-center double-blinded study looking at basically warfarin versus aspirin. And they found no difference in ischemic stroke, but a much higher rate of hemorrhage in patients receiving warfarin. And so basically, the punchline is no to anticoagulation, yes to antiplatelets. The cost study was multi-center randomized, was patients with ICA occlusion. And it was basically medical therapy versus bypass and medical therapy. It was terminated early for futility and because of the higher rate of 30-day ipsilateral stroke in the surgical group. And so, this one was basically no to bypass, yes to antiplatelets. And then there was Sampras, which included patients with TIA or stroke due to intracranial stenosis, medical therapy versus medical therapy plus stenting and angioplasty. This also demonstrated a higher risk of stroke or death within 30 days in the stenting group and a higher rate of stroke within the territory of the qualifying artery in the stenting group. And so this was no to angioplasty stenting, yes to antiplatelets. And so, Koss and Sampras really, for a while, if you look at the dates on these studies here, they were many years ago now, but really only until recently have we sort of reevaluated interventional treatment for this. And these studies really delivered a major blow to the thought of intervening for ICAD. But it's important to understand what Sampras medical therapy was. So it was aspirin and Plavix for 90 days. It was a target blood pressure of less than 140, less than 130 for diabetics, a target LDL of less than 70, a significant lifestyle modification program with a lifestyle coach who would check in with the patients every 2 weeks, with moderate exercise 3 times per week. I'm not sure what your all's patient population is, but I can tell you that trying to do this in a patient population in Chicago will not work. And so, what is real world medical therapy? And this was actually done from a couple centers in Chicago. So this is relevant for my practice, but, they looked at what is real world therapy and the ideal situation being dual antiplatelet and high dose statin. And for a variety of reasons, they did not give people some element of that regimen. But when we look at the real world stroke risk of medical management, we can see that we range at 20 to 25%, which is significantly higher than what was reported in Sampras. which was 4.4% in the 30-day stroke risk in the medical arm of Sampras. So, if we take this real world number and we plug it into the Sampras table, which is here, we can see that, maybe medical management is not so superior to the stenting and angioplasty group. And so maybe there's some role for stenting and angioplasty or intervention. Some things pertaining to Sampras in terms of the procedural arm, not the medical arm, but most patients were treated under general anesthesia, which can carry its own issues, particularly if there's significant blood pressure fluctuations upon induction. The enrollment for Sampras was based only on the lesion severity, so only on the degree of stenosis. So there was no effort to figure out who was hemodynamic failure and related to hemodynamic issues versus perforator occlusion versus vessel occlusion or stenosis. It was purely based on the degree of stenosis. And then they excluded patients that were fluctuating or had deterioration within 24 hours of randomization, which you could argue those patients would maybe be most likely to benefit. There was the wingspan stent that was used, which kind of has its own issues and some inexperience with that. And things were sized, the balloons for angioplasty were sized to the stent rather than the vessel diameter. And, now sort of doing this, many of us use conscious sedation in these situations. We can navigate the balloon primarily. We don't have to do an exchange and go across multiple times. And we have sort of started leaning towards a submaximal angioplasty rather than trying to restore the sort of native vessel lumen. And so if we dig further into Sampras and we say, well, they had this relatively high perioperative morbidity. Where was that morbidity? And so 12 of the strokes that occurred, there were 23 strokes that occurred in the stenting group. 12 of them were considered perforator occlusions. So basically, you sort of put this stent in and moved this plaque to cover lenticular striates and created strokes. 3 of the strokes in this group actually were in patients who were randomized to the group but never had the procedure. 3 were embolic. 1 of them was intentional after a perforation occurred. And then 2 were considered mixed and 2 to stent occlusion. So there was also this risk, this hemorrhage risk in the group. And, if we look into that a little bit further, there was no aggressive control of blood pressure after the procedure. And then 4 of these hemorrhages were actually due to wire perforation, which is, I don't know, in my opinion, seems to be a high rate of wire perforation. And, why did we have all this morbidity? And a lot of it was, I think, due to inexperience in patient selection, inexperience in managing blood pressure and knowing where that needs to be. There was a significant difference between the ICH rate, depending on the volume of patients enrolled in the study per site. And then, almost 10% of people received 2 stents, which is interesting. So, why are you placing 2 stents? Well, it's either because you kind of misjudged the placement of the first stent, you misplaced the first stent, or there's some sort of injury that you need to stent more. And so, I think, again, now we're really assessing people in a more physiologic way with functional imaging. We sort of keep their blood pressure very tight, and we eliminate crossing a lesion multiple times. And we do have better wires, balloons, and stents. And so, the next thing is, do we even need to stent? And this kind of goes to that submaximal angioplasty that I was talking about. And so, not stenting, it's just one less thing sort of in the blood vessel and perhaps can reduce morbidity a little bit. And things have sort of shifted more towards a submaximal angioplasty, I think, because of sort of the decrease in the risk of vessel rupture, the decrease in the risk of plaque rupture and embolism, and this idea that, with Pouzet's law, the flow is related to the radius to the fourth power. So even increasing the radius or the diameter of the vessel a little bit can increase flow significantly in an exponential way. And as one of our mentors, mine and Mandy's mentors, used to say, flow begets flow. So, you open it a little bit, and once you kind of open those floodgates, the continual flow kind of serves to help keep that vessel open. And so we don't need to restore the baseline diameter of the vessel to achieve that. And this is just in a group of 65 patients. The balloon was sized to 50 to 70% of the non-diseased vessel with a slow inflation, and a significant improvement in stroke-free survival with zero morbidity, hemorrhage, or 30-day stroke. And again, if you look here, the mean post-op stenosis was not, it was still 50% stenosis, but again, it served the purpose of restoring flow to the distal territory. This is just a meta-analysis looking at submaximal angioplasty, and the pooled rate of 30-day stroke or death was 4.9%. And again, so if we keep kind of coming back to the Sampras table, and I keep doing this because the Sampras study really defined a lot of how we manage this. And so if we start plugging these numbers into the Sampras table, we actually, things start to look a little different. But, is Pouzet's law enough? Is this just ancient, equations? We're really applying this to the assessment, how we assess our success for the procedure, right? We do this angioplasty on two planes. We use a 2D measurement. Perhaps we're counting frames to see what the angiographic delay is. But, is there a more scientific way? And typical to the story of neurointervention, we're kind of behind cardiology. And so in cardiology, they've been using this concept of FFR, or fractional flow reserve, to determine when they should stent vessels in the heart. Basically, they have multi-vessel disease, and how do you know which stenosis is the culprit? And so they measure FFR. And in cardiology, they've determined that an FFR of less than 0.8 is physiologically significant. And this is a case that we actually just got accepted for publication. It's a 62-year-old lady with 2 prior right MCA strokes, presenting again with this arteriofacial droop left hemiparesis. She was presenting sort of in this crescendo way. She has the usual risk factors, but at this point she had been optimized on medical therapy and her risk factors had been optimized. And so she underwent submaximal angioplasty sort of with the help of this cardiology technique. And so this is an 014 pressure wire that the cardiologists use, and the pressure sensor is 3 centimeters from the tip of the wire. And so what we did is we measured the pressure before, and then measured the pressure after the stenosis. And then we did our angioplasty. Truthfully, I first tried to do it with like a tiger retriever, and it didn't budge. And then we did it with a cardiac balloon, and you can see on the top angiographically it looked better. But what does that mean in terms of flow? I mean, I suppose we could sit there and try to plug it into the Pouzet's equation, but again, we measured this using this pressure wire, and after procedure, you could see we had a significant improvement in the perfusion parameters, both in blood flow, an increase in blood flow, and a decrease in the Tmax post-procedure. And when we looked at our pressure measurements, we basically improved the flow to basically what that means is that after the stenosis, 90% of the flow from before the stenosis was getting through the stenosis. So, we sent this for publication as just this to kind of throw out this idea that maybe we should start thinking about ways to be more scientific about this rather than sort of this gestalt that we all tend to use. So I'll kind of pivot to the surgical treatments now, which is a bit more controversial given this timeline. Really having two randomized studies, both the ECIC bypass trial and the COST study, showing no benefit to bypass. For those who don't know, just kind of, a bypass is basically isolating an MCA vessel here, and then this blood vessel here is the STA, the superficial temporal artery, that is getting sutured to the MCA vessel. And then you can see basically now we'll give blood flow to that vessel. And so we look at the table from COS. It concluded that there was no benefit to ECIC bypass over medical therapy. Some considerations is that these were neurologically stable patients. They had just had a single qualifying ischemic event, and sort of post-op or anesthetic care was just kind of left to the center. It was not sort of part of the trial. And the two things that came out of the COST trial were basically there was a higher than expected surgical morbidity, and there were better than expected medical outcomes, and that sort of led to these curves that we see here. But what if we think about sort of a more long-term benefit? If we continue these curves, we see that they sort of diverge. And in fact, when I believe this was a study out of Taiwan, if you looked at these curves, over many, many years, you could see that with time, these curves diverge even further. And then, what if we were decreasing surgical morbidity? So if the surgical morbidity was halved from 15 to 8, and the reason I'm saying like this isn't just some esoteric, what if 8% is sort of fits with more contemporary bypass series in terms of the morbidity. So if we halved that morbidity to 8, we see that curve looks a lot different. And the thing is that most of the strokes, or sort of perioperative events, happen during the first 2 days. The first 48 hours are really the most critical after a bypass. And if you eliminate the first 2 days, you can see that the risk of recurrent stroke subsequently is significantly higher in the medical arm of COST than in the surgical arm. Again, contemporary series, show a much lower morbidity. And interestingly, the patients that are getting bypasses now are much different than the patients getting bypasses in the COST trial. The patients getting bypasses now are much sicker, and arguably ones that need bypass more. Or another way of saying it is that perhaps the people in the COST study didn't need the bypass. So I think nowadays we might be a little bit more refined in our patient selection for in using bypass for intracranial atherosclerotic disease. And this is a case that we had. It was a 48-year-old woman who had presented to an outside hospital with sudden onset of left facial droop and hemiparesis. And she had hypertension, diabetes, and end-stage renal disease requiring dialysis. When she was transferred to us, our stroke neurologists get the call, they'll tell them, hey, put the patient flat, put them on fluids, etc. And if it's appropriate, give thrombolytics, etc., etc. But by the time she got to us, she was intact, and so we had the luxury to sort of work things up a little bit. And This was her MRI with the sort of watershed distribution stroke, and then her MRA, the time of flight MRA showed this. And while she was admitted, she was getting dialysis, and with every dialysis session, she developed left facial droop and hemiplegia. And it was like, clockwork. Every, second or third day, dialysis, stroke code called. The lady had like, 20 MRIs, and they would try to adjust the dialysis to be a more gentle dialysis. Every time she would get hemiplegic, and then she would recover. And, this was her perfusion study. We can see a significant increase in her Tmax after the diamox, suggesting impaired cerebrovascular reserve, which she also demonstrated to us through her symptoms with dialysis. So I did take her for angio. Wasn't the healthiest candidate for a bypass, and we really tried. Was able to get through this sort of proximal part and was able to get into a lumen, but up here in the cavernous segment, this was completely occluded. And I mean, I was trying to use the cardiac CTO wires, and I mean, nothing would go through this. And so, really, so what do you do with this patient, right? So, I mean, all these studies would suggest, well, you just give her medical therapy. Well, she was getting medical therapy, but, becoming hemiplegic with every dialysis is not really a way to live life. So we did take her for bypass. I did a double barrel bypass. So I took both branches of the STA. Here's the first branch going into this portion of the MCA, and then the second branch coming here, and the post-op CTA. And literally after the bypass, she had no other episodes of hemiplegia with dialysis. She tolerated every dialysis subsequently fine. So, I think, again, this speaks to that there is a role for bypass in treating atherosclerotic disease. And so, a lot of it is focused on decreasing the morbidity of the bypass. And so I think, as you could see from that comparison of the patients who are getting bypassed now compared to the cost study, I think we've done well in refining our patient selection. And I think that, practice is also an important aspect of it. So, around every Thanksgiving, we do a turkey wing anastomosis lab with our residents, where they can practice all the different kinds of bypasses. And I've sort of gotten into, with each year, kind of time the residents and see how they do. And, it becomes these are, 1 millimeter, 2 millimeter blood vessels. And so, these are 10-0 sutures that are so small that we don't even count the needles because you can only see them under the microscope. And so there's a muscle memory aspect to this. Even myself throwing my first couple stitches in the bypass is much more clumsy than throwing the last 2 stitches. And so it becomes, a big muscle memory thing. And, being in Chicago, we have to show, Jordan with his muscle memory from the free throw line. And, I think these microanastomoses are not unlike that. So, I think there is a role for ECIC bypass in treating ICAD. I think it's in patients who have recurrent and progressive symptoms that are due to hemodynamic failure and who have failed medical and/or endovascular therapy. I think, again, demonstrating that there's impaired cerebrovascular reserve is important. And again, demonstrating that the stroke is due to hemodynamic failure, border zone ischemia, and not perforator syndromes. And so we've really adopted kind of the stepwise approach for the management of ICAD. And, of course, we do start with medical therapy. We're also part of the Captiva trial, which is assessing the role of the new DOACs in ICAD. So that's part of this now. But again, 20 to 40% of people will fail that. And so if we can, we do try to do submaximal angioplasty or endovascular therapy. And it's, if they failed that, or for some reason that is not an option, we do consider bypass. And so how do we implement this? Again, I think it's really, initially when I came to Rush, it was like, oh, the stroke is due to ICAD. But we really sort of educated and pushed to really understand what mechanism within ICAD is causing the stroke. Is it hemodynamic failure? Is it perforator syndrome? Is it an embolus, et cetera? We also developed that comprehensive clinic that I referred to. So me and one of the stroke neurologists, we see patients together in a sort of a comprehensive clinic, and we also follow these patients with objective measurements serially. There was another patient, it wasn't ICAD, but it was Moya Moya, who we followed, was asymptomatic, but in our serial imaging kept showing worsening reserve, and then came back with a small occipital stroke, ended up getting and needing bypass. So I think following these patients with objective measurements radiographically over time, I think is also beneficial and important. So in conclusion, I think that medical therapy, as practiced in the real world, we need to recognize that this is not as effective as Sampras. And so I think if we're being honest with ourselves and our patients when we counsel them on the risk of stroke with medical therapy, I think we need to use numbers like 20%, not 4.4%, unless they really are truly a motivated patient and are going to do all the things that were present in the medical arm of Sampras. All that being said, I know I've sort of been, as the surgeon, been poo-pooing medical therapy for most of this talk, but it's a safe therapy, and so there's very little morbidity to it, and so I think it's a very reasonable first-line approach, and we do employ that approach as a first-line approach for every patient with ICAD. So again, we don't consider even endovascular intervention unless there's been a failure of medical therapy. Submaximal angioplasty improves flow. There again, Pouzet's law of radius to the fourth power. We don't need to have a perfect looking angiogram to be effective clinically. And again, on the FFR realm, is there a need for us to be more scientific? What's the threshold? The threshold for the cardiologist is 0.8, which means only a 20% reduction in flow. I suspect that that's not the same threshold that we would use, but we need more data and need to understand that further. And I think ECIC bypass, again, remains a viable option of revascularization in patients who have persistent symptoms despite medical therapy and endovascular intervention. So again, I'd like to thank Rudy and Mandy for the invitation, and I can take any questions. I think I saw something come through on the chat. Oh, that was Nicole.
Okay. Actually, yeah, I do have a bunch of questions, and that was a great talk. Thank you so much. I'm actually getting a bunch of questions texted to me as well. So just for everybody on right now, if you go to the chat, you can claim your CME credits. But then in addition, we have one really good question is, if you were going to redesign like a Sampras 2 type trial, how would you design it? Maybe what, I know some of the stents you were talking about that are better than Wingspan are not necessarily on label. So how would you design the trial, and what devices would you use?
Yeah, I think the most important thing is that is differentiating the mechanism of stroke. I said, why would dual antiplatelets really be beneficial for something that's a hemodynamic problem? The flip side of that is, why would a stent or an angioplasty help a perforator syndrome? Mm-hmm. It wouldn't. And so I think differentiating the mechanism of stroke is the most important thing for like a redesign trial. And again, I don't think there's a role for endovascular therapy or bypass in somebody who has a perforator syndrome. That doesn't make any sense. So using the mechanism of stroke as the primary determinant for inclusion, I think would be the most important. And
Would
then,
you incorporate any kind of vessel wall imaging or anything for that?
yeah, we do use it, like I said, and we've seen regression of the enhancement in the plaque with improvement in risk factors. I don't I don't know how that plays into either hemodynamic mechanisms or, how that plays into any sort of intervention. I think probably more to come as we get more data on that. But yeah, I don't know how that plays into anything.
Okay, and then with submaximal angioplasty, it's sort of a two-part question. Um, what would you say restenosis rate is? And also, do you monitor with imaging for restenosis or do you go purely based on symptoms?
Yeah, so we do monitor. So the rate of restenosis, it's strange. There's people who, and I don't understand why some people do and some people don't, basically. There are people who we've brought back 2 and 3 times to try to give them a chance with angioplasty before needing something more. Um, and I think the rate is probably somewhere around 20%. But that means 80% are fine with just, the angioplasty. So I think it's certainly worth giving almost everybody a shot at angioplasty before needing something more. And I don't know why some people restenose and some people don't. I haven't been able to figure that out, but we do put everybody on dual antiplatelet therapy who we're going to do a angioplasty on.
Yeah. And are you checking Plavix response?
Yes, we check Plavix response. If they're not responsive, we switch them to Brilinta usually, and then we do monitor them. Again, the comprehensive clinic has been nice because it forces a little more follow-up. I think our attrition rate and our loss to follow-up rate is a little less since starting that clinic. And so we do follow them with either CTA or MR. But again, the MR has its and also perfusion studies. Because if there's any question of stenosis getting worse, you can kind of use the perfusion as a correlate to help if you're on the fence.
So let's say it gets worse just via imaging or perfusion, but the patient's asymptomatic. What do you do?
So usually we'll most of the time follow them with the Diamox studies too. We will usually, if they're asymptomatic, drive up any medical options that we have.
Yeah.
Either drive their LDL lower, again, as we were sort of talking before, the GLP-1 stuff, like how does that play into all of this now?
Yeah.
So we'll try to adjust those things, but we tend to wait until at least something shows up clinically. But again, I think it's really tough. A lot of these patients are not the healthiest patients, right? So, if they have 3 perfusion studies that are getting worse and worse and worse and worse, then we will kind of jump in. But an isolated one, we kind of try to maximize their medical risk factors.
Okay. There's been a lot of, well, not a lot, but several papers recently, and even a trial looking at EDAS for like an indirect bypass for ICAD. And, apparently, obviously the patient that you presented who was sort of map dependent in the hospital wouldn't qualify for that. But do you do any EDAS for ICAD?
Yeah, so those are less for ICAD. I know it's a little bit of a deviation from this talk, but more for Moya Moya.
Yeah.
The asymptomatic patient with worsening reserve, I'll tend to indirect versus direct. the few indirects that I've done for ICAD have not taken very well. And
Really?
I think it's just because, these are like the older, atherosclerotic, like not great, right? I mean, as we know from the Moya Moya stuff, right? Like indirect bypassing kids works the best, right? And as you get older, it works less well. So I think just from the patient population, at least in my experience, it has not been as effective.
And then last question was, we were talking before this started. You have residents, you have vascular fellow, and you're talking about your turkey wings. How are you keeping up the competencies for bypass?
Yeah. You know, I'm extremely type A. And so I'm still very hands-on for the STA MCA bypasses. But we do try to get them, for me, it's very much on an individual basis and what the resident is like. And, just because you're a chief, you don't get to like do the anastomosis type of thing. You have to kind of demonstrate that there's some competency there. But, it's, uh, yeah, we do the turkey wings. If it's been a while since like these tend to come in waves for whatever reason. Like I have, 4 coming up in the next like 3 weeks, but the last month I haven't done one, right? So and that first one, a lot of times what I'll do actually is the OR is getting set up, I'll just with the microscope sit there with one of the 4 with the 10-0 sutures and sew the threads of a 4x4 together,
Okay.
just to kind of like get the muscle memory. It's like when you to some degree I think it's like riding a bike, but
Yeah.
if you're in a Chicago winter and you haven't ridden your bike for 6 months, the first time you get on it you're a little bit wobbly until you get the pedals going. And so just throwing even just a couple, a handful of sutures just before the case, I think is very helpful.
All right. Well, thank you so much. And that was really a great talk. I think this is one of, like you said, sort of one of the more, maybe not controversial, but not the most straightforward thing we treat in vascular
For sure.
neurology and neurosurgery. And, we get consulted for ICAD all the time. And then you always want to know, FDA says you have to have 2 strokes on medical management before you can place a stent, but it's hard to see someone, like you said, with a flow-related problem and expect them to respond to medical management. So I think we tend to jump in after the first stroke on medical management. So
Yeah, definitely. I think that's the most important thing is understanding that there's multiple mechanisms within this umbrella of ICAD.
yeah, for sure.
All right.
All
Well,
right.
thank you
Well,
very
thank you
much.
so much.
All right. Take care.
All right, you too. Bye.